Welcome to MedEd's production of the Pain Management Nursing Exam Review. My name is Kendra Menzies Kent, and the title of this module is Addiction, Physical Dependence, and Pseudoaddiction. What we're going to cover in this module today is the patients that we deal with that come in with histories of addictions or histories with physical dependence, how to recognize some of the addictions, how to manage patients that do have the addictions, and what is pseudoaddiction. All right, we're going to talk a little bit about that. What are the pseudoaddictions that it looks like the patient may be addicted to a drug, but may be actually still in pain or are looking for pain medications for that purpose. So we are going to cover some of these big issues that we see on a daily basis in a lot of the hospitals that we work in. So in introduction, just to give you an idea of the incidence and the number of people that we're talking about on this, there's an estimated 12 to 21 million people worldwide that abuse opioids, with 1.9 million people here in the United States with opioid abuse. Opioid dependence, now on the other hand, affects nearly 5 million people here in the United States. So you can already see, based on these statistics, that there is a difference between an opioid abuse and an opioid dependency. And we actually have a lot greater number of people that are dependent on the opioids. Opioid abuse and also opioid use leads to approximately 17,000 deaths every year here in the United States. And we're going to talk about that as well. When we look at some like CDC analysis, this was brought in 2012, they looked at the prescribing data that's collected from like your pharmaceutical, or not your pharmaceuticals, your pharmacies, on the data of the prescription drugs. And it showed overall, 2012, healthcare providers wrote 259 million prescriptions for opioid painkillers that year, and that 46 individuals died each day in the United States from an overdose of the painkillers that were actual prescriptions. So, even just looking at some of this, we know it's a national issue. It's a problem that we have to address. Individuals with substance use disorders are among the highest risk populations for medical as well as psychiatric rehospitalization. So it's an issue that we have to look at. When we're looking at definitions, right? So again, we said there's a difference between abuse and dependencies and addictions and pseudo-addictions. So starting and looking at some of these, to start with, substance abuse disorders. How do we define it? What is that? It's a condition that is resulting from the inappropriate use of prescription drugs, alcohol, and or illegal drugs. All right, so it doesn't specifically, when we talk about substance use or abuse, we're really not looking at just prescriptions or opioids, but it's across the gamut. It can be alcohol, it can be illegal substances, but it's a substance abuse disorder. The AMA Council for Scientific Affairs panel on Alcoholism and Drug Abuse Task Force actually defines substance abuse as a use of a psychoactive substance in a manner that is detrimental to the individual or to society, but not meeting the criteria for substance or drug dependence. This is more for that recreational. It's not patients that are in pain or have started maintaining it because of their pain. It's more for that recreational use. So again, terminology-wise, what is addiction? Addiction is an acquired chronic disorder. It's chronic. Even if people stop taking their drug, if they're a heroin addict and they've gone through rehabilitation and they're no longer taking the heroin, they are still addicted. It is chronic. All right. Same things with cigarette smoking. It's addictions. It's chronic. They can stop smoking, but there will always be that craving or that compulsiveness to that drug. That's what makes it a chronic disorder. So when you look at what characterizes your addictions, it is that compulsive use. All right, it's the craving, it's the physical, psychological, and social harm that results from this craving, and they still continue to crave it. So they can lose their house, they can lose their loved ones, they can lose their family, their job. They still crave the drug, all right, whatever that drug or that substance may be. So really when we look at an addiction, it's a loss of control. It's a denial of their potential harm. They'll say, hey, I didn't need that, or I don't need to go there, or, that's okay. And they continue going for the drug, even though their life is falling apart or they've lost their job. So really when we look at addiction, majority of the definitions are going to include something that has to do with compulsion or an overpowering drive that they have to have that substance. One of the substances that can become an abuse situation that is considered a substance that is abusive is the opioids, all right? But now here's where we start to get into issues, and that the chronic use of an opioid does not mean the patient is addicted, all right? And so that's where we get into what do we call red flags for addictions versus taking a look at why else are the patients using an opioid, all right? It may be for pain management, and if they are chronically on an opioid and it is being taken for pain management, that is not an addiction, all right? It's just to control pain. Now, what else can we get into in the way of terminology is what's called physical dependence. And even these patients that are taking these opioids just for pain management purposes can develop a physical dependence, all right? So physical dependence is completely different than the addiction. Remember, the addiction is a craving. Physical dependence means that the body has adapted, usually at the cellular level, when we get into looking at this, to that substance or that drug that that person is taking. So again, it can be a chronic pain patient that is taking opioids on a daily basis, but their body's adapted to that drug. So now when you suddenly stop taking the drug, we get withdrawal symptoms, right? That's what defines a physical dependence. The other thing about a physical dependence is that it may also start to develop some resistance to the drug, where you have to take more of the drug to get the same effect, all right? So you start to develop a little bit of that drug resistance on that. There is a cross dependence, meaning that if somebody is physically dependent on an opioid, then what you'll see in the way of a cross dependence is one opioid to the other, or one substance to the other. Alcohol, street drugs, illegal substances can also develop some physical dependency that crosses over. Again, this is not an addiction. It's completely independent from that. But it does mean that if you have someone who's physically dependent and we want to stop, or we want to get them off of that substance, then instead of just stopping it suddenly, we need to taper the drugs, right? So that helps be able to withdraw them from the drug without all the withdrawal symptoms that we can see with that. That's your physical dependence. We also have a psychological dependence. This is defined as an emotional craving for the positive effects of the substance or to avoid the negative effects. That goes down into your addictions. A lot of times what you'll see in substance abuse or substance addictions is they originally get that high, that first groupings of taking that heroin, it really makes them feel good. So then the hypothalamic area of the brain starts to crave this. They start wanting that drug over and over. They get to a point now, it really no longer gives that positive effect, but they know if they don't have it, it's going to be even worse, right? So there's a point they're not even getting that good fill or that high or that positive. They're just trying to avoid the negative of the withdrawal. That becomes a lot of your psychological dependence on it. Tolerance is defined by either a need for a marked increase in the amount of the substance to achieve the same effect, all right, we see that in a physical dependence, or a markedly diminished effect with the continued use of the same amount of the substance. Patients that are on chronic opioids for chronic pain develop tolerances, all right? They have that physical dependence that they can have a withdrawal, and they develop tolerances where you have to go up on the drug to get the same effect, all right? Or they're going to start to have more pain breakthrough on that same level of drug that we've been administering. So again, just as a review, we've got the addictions, which is your cravings. You have your physical dependence, which can result in withdrawals when you suddenly stop a drug, but it doesn't involve all that cravings. And then you have your tolerances. And your tolerances, again, is where they may need to go up on the drug because they've been on a substance for a while that the body builds a tolerance to. So those are some of the terminology, and as we go through there, the rest of this lecture, you'll find that it's not always easy differentiating addictions from people that are on chronic use of prescription drugs. All right, it's going to be difficult sometimes to look at these, and we're going to talk about drug seekers, and we're going to talk about not calling them drug seekers, but we'll get into that here in a minute. There's so many different reasons people are seeking opioids, and we're going to get into that. All right, so it may not be that they're just addicted, and it is going to be a very difficult, is not a perfect black-white. There's a lot of gray areas in here, and that's what we're going to address in this lecture. So when you look at people that have been seeking drugs but who are not in pain, all right, that would be looking for it more for the craving for the addiction. It is actually also becoming more common. 15, 20 years ago, we didn't see as much as we do now. Recent statistics even show a 34-fold increase in fatal opioid overdoses since 1999. So what's new, what's out there, are now called Narcan pens. And these are actual pens that are administered just like your anaphylactic pens that have been out for a while. Then the side of the thigh, it's Narcan to reverse the opioid overdose. It's controversial in some areas, but patients, for example, that are on large doses of an opioid, let's say to manage their chronic pain, accidentally take an overdose, then there's family members that can be prescribed these Narcan pens that can reverse it, and of course then seek medical help. So there's some of that now available, but a lot of it's because there's been so many fatal overdoses. We have to look at a plan to counteract that. It becomes pretty ethical debates at this point in time. But when you look at, even in the hospital, some of the biggest dilemmas and debates and ethics that we get into are common complaints that we have as healthcare providers. We have people that are saying their pain is a 10, which we should say as a healthcare provider is the worst possible pain you could ever imagine, and they're laughing and talking on phones. So a lot of nurses then start to feel like these patients are seeking the drugs for the benefit of the drug, not for pain, but for the highs or the feel goods. Or people that clock watch or set the alarms. There's some misconceptions on this. And we're going to talk a lot more about these under pain assessment. But keep in mind, just because that's happening doesn't mean that the person doesn't have pain. It doesn't mean that they're not looking for the opioid for pain management. It may mean they're not totally understanding the scale of 1 to 10. It can mean that they really don't know what the worst possible pain really is, or they know that they don't want to have pain, so they're going to take it before they have pain. They know they're going to get the drug if they say a 10. So again, there's a lot of different underlying reasons for seeing what we do, but a lot of the healthcare providers or the nurses will feel like that's a sign. So we're going to get into some of these, what we call red flags for that. So we do know there is issues with overtreatment, because we have the fatalities, but we also know there's issues with undertreatment for pain. Overtreatment, there's a lot of prescriptions out there. There's a lot of states that have very high prescription rates that are being cut down on. But again, on the flip side, we have undertreatment as well. In a joint statement, 21 health organizations and the DEA clearly stated that undertreatment of pain is still an issue. Joint Commissioner JACO considers pain assessment as the 5th vital sign, meaning every time we set of vital signs, we have to look at pain assessment. The cracking down of these prescription misuses, getting into these states and these physicians that are like over-prescribing these opioids, that's a good thing, but the cracking down on it means that we may be under-treating those patients who really do have pain. So again, we're still walking this fine line of what is too many prescriptions and too much leniency in handing out opioids and over-treating, compared to if we crack down too much, are we going to let people that have pain get by without getting the opioid prescriptions they need? All right, so that's where some of the dilemmas come in, and that's again what we're going to look at. And a lot of healthcare providers are like, I know what it looks like when somebody comes in seeking drugs for the high. And maybe we don't, all right? And that's where we're going to get into it. It is a little harder to distinguish these patients from those who really truly want pain relief, and that's why they use the opioid, to those patients that are taking it because they want the high, they like the intoxication, or they're using it for recreational use. So again, being able to tell that is not always that easy. All right, we're going to go through some of those red flags, but for every red flag you can present that says this is a sign that it's for the abuse or an addiction, we can pretty much counteract that with this is also why you might see it in somebody that actually has pain. So it's not, like I said earlier, that true black and white. One of our big issues on it is drug addictions and pain may not be totally mutually exclusive. You might not have it on that dichotomy here that it's either a drug addiction or they have pain. You might have a drug abuser that has been using it for their addiction present now with a true acute pain, right? So there's a little combination in there. Or you can have somebody who has pain that actually starts to develop some of the addiction, all right? Starts to develop some of the liking of the way they feel when they're on that drug, but they're primarily still taking the drug for pain purposes, okay? So we may not have that true dichotomy. There are some thoughts that you might have 50% of this as being addiction and 50% of it being chronic pain, or 80% pain and 20% addiction. So we might actually have a little bit of a combination in here. When you're looking again at chronic pain patients, there's a thought that maybe anywhere from 2 to 40% of them, and again it depends on the study you look at or the article you read, may begin to abuse their opioids, even though the main reason they're on the drug is for pain management. Taking it another step, look outside of opioids. 40% of the patients with chronic pain who are on some sort of a prescription drug may also be abusing alcohol. So it may not even just be an opioid, but it can also be a different substance that they're also taking along with that. The true prevalence of like drug abuse among patients who complain of pain is very difficult, right? It's very difficult to determine. So even in these studies that get quoted, you know, it's always, you come down to the point is, did they really have pain or not? So where do we stand in our pain management group? We still have to look at self-report. And I can tell you based on the studies, self-report does not always correlate to the amount of medications that they get. All right, but we still need to look at self-report. There's a lot of inaccuracies. There's a lot of times you have patients with self-report say there are tons, but they may not be getting anything. So, you know, if you're looking at the self-report side to it, we may not always see that it correlates well to how much drugs that they are getting for their pain management. There's also a lot in that self-report on the flip side that patients will say, yeah, I don't take it very often, but we find out that they've been taking it on a daily basis. You know, so it's a similar thing to like the alcohol. Those people that are addicted to the prescription drugs, it's like any other substance they're addicted to, they're not going to be always telling us the truth on how much, how often. You know, so 90% of the patients who are on prescription opioids may deny it. So it's still going to be difficult to look at self-reports on that. So let's talk about drug seekers. I'm pretty sure everyone's heard that term. They're a drug seeker. They're in the emergency room because they're seeking drugs, or in the hospital, they're asking for pain meds because they're a drug seeker. Really, if you look at that drug seeking is a set of behaviors. It's behaviors that appear that this person's purposely trying to obtain a drug. Okay? Now, what it comes down to is, why are they purposely trying to get the drug? There's several reasons that we call people drug seekers. One is a patient that is actually truly in pain, but they're not getting their pain managed. All right, they've gone ER to ER, clinic to clinic, they've gone to different physicians. The physician says, you know, this is what you need. I'm not going to give you anything for that. And, you know, nobody's really truly looking at their pain and managing their pain. And it puts people into that environment where they literally have to go from ER to ER to get their pain meds and to get prescriptions. But they're not doing it for their high. They're not doing it because of an addiction. They're doing it because they hurt. They're in pain. All right? That's one of the reasons we see the behaviors of what we would call a drug seeker. The second one is person's addicted. It is a substance abuse. All right? There is no pain, but they're using it for the high. They're going to do that same sort of behavior. They're going to go from ER to ER, clinics to clinics. They're going to be in our acute care facilities, always asking for pain management, for analgesics. They're going to tell you they hurt when they don't. All right? We have that group. We know we do. Those are your substance abusers and your addictions. We also have a third reason people will go from place to place and try to get prescriptions for their drugs is that they're not in pain, but they're also not addicted. So they don't show you all your addiction qualities. What they're doing is they're taking the drugs, filling their prescriptions, and selling them on the street or giving them to somebody else. All right, we'll see that as well. So really, when we say somebody's a drug seeker, that's just a set of behaviors that gives us the red flag that they're looking for prescriptions. Underlying reasons for that is going to vary greatly based on the person. All right. So again, we have to not always label people. Number one, we don't really want to call anybody a drug seeker. All right. That becomes a label. But part of it is it labels people that truly have pain and need that pain management. It labels them as if they're an addiction. So this is where we talk about it as being a pseudo addiction. Remember that terminology in the beginning. I said we'll go over what the difference between addictions and pseudo addiction. And a pseudo addiction is somebody that appears to be seeking the drug for a non-pain management purpose, but it is really actually for pain management. All right, that's when we considered it to be a pseudo addiction. It is truly to relieve their pain. These are people that are poorly managed in their pain to begin with. They've never been to, let's say, a pain clinic. They've gone from physicians who really don't know a whole lot about pain management to physicians who may not believe they have pain. And so this pseudo-addicted patient then begins to become very focused on getting their drugs. They watch the clock. They appear to be seeking the drugs, but they're really not in an addicted situation. So we call these pseudo-addictions. So what do we need to do at the clinical side? Number one, like I said, avoid the term drug seekers because it gives a bad image to that person. It's a label, and that label stays with them. It has a very negative meaning to it. And when you label somebody a drug seeker, most people think drug addictions. All right, they don't think outside saying, oh, it could actually be a pseudo addiction. Literally, they think addiction. So this person may not be treated for their pain when they have pain. This person may miss their diagnosis or miss complications because nobody believes them because they think they're seeking drugs. So again, totally avoid it. Do not document it. Don't give it in a report. Don't say this person's a drug seeker because it puts that label. And then what's going to happen is we're not going to treat people that have pain. We're going to inadequately treat their pain. Let me give you an example. This was a legal case. This was not anything I looked at, but it was an orthopedic case that was in the literature. There was a lady who had a fracture, tib-fib fracture. She had gone to the OR for internal fixation and external casting. And the PACU had noted to be pain beyond pain meds, and they kept giving her some Dilaudid and fentanyl in the PACU. One of the PACU nurses pulled her chart and went to look at her history and found on history that a physician had written in the chart that this patient was a known drug seeker and had an addiction to opioids. All right, so they labeled her a drug seeker. So now what happens is they kind of go back and stop treating her pain. And they don't look any further to figure out why she's having so much pain. So she goes from PACU to the med-surg floors. Over the next 48 hours, she complains of pain beyond pain meds, throbbing sensation, paresthesias in the leg that's casted. Pulses are still there, so they feel like, there's nothing wrong with this. And they treat her some for pain, but they really don't address the pain. They don't figure out why her pain is so severe. Finally, at the time of discharge, the patient says, I'm not going home. What do you mean discharge? This hurts. Nobody's fixing my problem. So now the physician comes in and opens the cast, and they take her in for a fasciotomy, and the muscle's all dead. All right, there's no muscle in that leg. It's totally dead. And that's because she's had compartment syndrome for the last 48 hours and is no longer perfusing her, her extremity, her muscles. So that's what we mean by it can miss complications, it can miss your presentations when we label people. The position statement that's put out by, again, our American Society for Pain Management Nursing in patients with addictive disease recommends the term not to be used because it creates biases, prejudice, and barriers to care. So again, just don't use it, all right? And the other thing is, do we really need to fixate on this? Do we really need to try to decide, do I believe my patient or not? You know, if I work in an acute care area, patient comes in with a fracture or a knee surgery, there's a known reason for pain. So do I really need to sit there and say, all right, this patient's been on the call button, they're wanting more and more pain meds, they got to be drug abusers, they got to be addicted to drugs. Do I really need to do that? Or is it self-report? Patient says they have pain, we treat them accordingly as long as they don't have side effects or complications from the drug, like respiratory depression. So again, we really have to stop fixating in a lot of these settings on whether we believe the patient or not. Now, certain settings may be a little different. If you work in pain clinics, then part of it is to try to get down to what is causing pain. If you work in an ER, you can't just give a lot of prescriptions in and out of the emergency room. You know, so again, I think you have to really look at where you work. But most of us work in acute care areas. We need to not always try to decide, do I really believe that person or not? There's no one definitive way to determine if it is for the addiction purposes on that. And we have to be careful, again, we don't judge them or not treat their pain. So, you know, we're going to see it all the way around. We see all these problems based on these dilemmas. Over prescriptions, over treatments, drug-related deaths. Under treatment, difficulty with pain management. If we don't treat well enough in pain clinics and outside clinics, we're going to overcrowd our emergency rooms with people trying to seek emergency care for their pain management. It increases healthcare costs. If we don't have really one good team managing pain, sometimes it develops a lot of tolerances, cross tolerances, and can increase their dosing, and then it can contribute to a lot of the psychosocial complications of that. So what have some states done, and actually majority of the states now here in the United States have some sort of a state registry that is trying to help determine if this person's doing behaviors that may indicate that they have an addiction to the drug. Remember, we're not going to call them drug seekers, they're just behaviors we're looking at. And each state registry may be a little bit different, but what they have shown now that we started using it, again, you really don't know 100% whether somebody is an addiction or not. What they found in some of these state registries is patients that have relatively normal behaviors, who are not doing anything that you would call red signs for addiction, may have 50 prescriptions written in the past 2 months. There's a lot of reasons for looking for these prescriptions. Or we find a patient has very suspicious behaviors. Patient, doctor to doctor, symptoms changing, but they really have had no scripts written in the past year. So they don't really have an addiction to it. So it has been showing that it helps a little bit follow trends. Where's this patient gone to? How many prescriptions have they had? How many have been filled by pharmacy? How many ER visits do they have? It looks for some of the behaviors that we would look for an addiction. Some of the problems with the state registry is it's a state-by-state nature, so there's not always a crossover. So if you live on a border, you could go to the other states to do it, and it would not talk to each other. All right, and that's the majority of the states. Military or VA hospitals are not typically in the system. Mail-ordered prescriptions or going down to Mexico or Canada to get your drugs isn't going to be reported. And then like each state varies on how many months of data is available and what schedule of medication is actually being recorded. So again, there's some variations and there's some problems, but the system seems to be helping a little bit identify some of these behaviors that we're going to look at. So what are the red flags? The red flags, example, Annals of Emergency Medicine in 2013 reported several what they call red flags that are associated with suspicious behavior, and a lot of these were based on that registry. All right, what kind of patients came in? We're still getting a large number of scripts from ER to ER, clinic to clinic. One of the, if you go through the list, asking for opioids by name. No, I don't want morphine. I want Dilaudid. All right, asking for the opioids by name. May claim an allergy to all medications except for their drug of choice. Yeah, no, I'm allergic to that one. No, I'm allergic to this. The one I'm not allergic to is, that may be a red flag. Multiple visits for the same complaint. Suspicious history, telling inconsistencies of why they're seeking pain medication. Their reported symptoms are out of proportion to the exam. So you may, and we've seen it, people come in and they're appearing to have a seizure, but there's no EEG activity. The seizure activity is not real accurate seizure activity, but they're faking their symptoms or their disorders, or they're out of proportion to what we find on our physical side of the exam. These are red flags. Now keep in mind, and we're going to do some of this here in a minute, I can pretty much go line for line and give you a reason somebody in pain may also present like this, all right? So they're not 100%. Other red flags that have been identified, and I think, again, most people in the room listening to this will be rolling some of these off as well. Going to different emergency rooms, asking for refills of prescription or drugs that were lost or stolen. Again, one time is probably not too big of a red flag, but if you have someone coming in frequently saying, I've misplaced it again, I've lost it, or my prescription got stolen, you have to start looking at how much of the drug they're actually taking. A preoccupation with their opioids during the visit. Instead of trying to find out more about their disease process or their injury, they keep asking about the drugs that they're going to get. I love this one. Patient tells the nurse where to give the drug and how fast to give it. All right? Give it this IV because it's closest, and give it as fast as you can give it, and don't dilute it. All right? That's usually not meaning they're looking for pain management as much as they're looking for the high of the drug when we give it. Those are some things we look at. Inability to restrict medications or to take them on an agreed schedule. They keep needing their refills sooner, or taking multiple drugs together. Doctor shopping, one doctor to the other. Persistent euphoria, increasing levels of sedation, decreasing functional levels despite pain relief, or we're starting to see now an increase in psychiatric problems like anxiety, depression, different types of presentations like that. So those are what we're going to call some red signs. Again, I'm going to give you some what I call devil's advocate to these, but those are kind of our red flags on that. I do so that in the way of, again, looking at studies. As a healthcare provider, we tend to suspect addictions more often in men, but when you really look at these state registries, we find that a lot of those tend to show the suspicion is actually more with women. All right, so these are our prejudice. These are our biases that may affect how we treat someone's pain because we're seeing it as an addiction. Abusers do tend to be younger. One study found a mean age of 34 years of age. But you do sometimes find elderly. It decreases, granted, over the age of 65, but sometimes you will find the elderly. Sometimes you're going to find an 18-year-old that it's really pain. So again, these are just statistics. They're not 100%. So what is highly predictive? All right, there's a couple of things that we do all agree that would be a highly predictive that this is an addiction and not truly looking or asking for pain medications for pain. First one is a previous history of chemical dependence. All right, they have a known history of heroin use, alcohol use, substances like that. To truly try to decide, let's say they're in a pain clinic and we're trying to do a workup on whether they truly have chronic pain. Sometimes urine drug screens will help. If they tell you they have not had any of their chemical substance in the last 6 months, a year, then do a drug screen. If not, then they may really be experiencing pain. All right, so we can look at their previous history. Other potential predictors is a family history of chemical dependence. Means they're more likely to develop that. History of childhood sexual abuse, history of convictions for driving under the influence, and then the use of supplemental sources to obtain their opioids, like mail prescriptions and getting prescriptions from other people. Those are used, again, pretty good potentials. But bottom line, it's never cut and dry. All right, it's never cut and dry. So let's talk about some devil's advocates. All right, we got all those red flags. Pretty sure everybody is, yes, seen that. Yeah, I would say that's a red flag. Now let's look at the opposite way of looking at it. This patient that comes in and requests the opioid by name. What if it's a chronic pain patient? They've been on a lot of different drugs. They probably do know those drugs by name, and they probably do know which one works best for them. We see this with sickle cell sicklers that come in crisis situations. They've been treated for a while. They know what works best for them. Does that really mean they're addicted? All right. Maybe they're just very aware and familiar with that and request the one that works best for them. Maybe this patient going from ER to ER with the same complaints is that nobody's truly ever addressed their underlying etiology. Physicians have not been able to identify correct diagnosis, hasn't been able to do correct treatment, and that's why the patient is having frequent visits to clinics, doctor shopping, and emergency rooms. Okay, lost medications? You're right. Once or twice we might say, if they do it on a frequent basis, surely it's an addiction. What if it's an early onset dementia? What if they've got cognitive impairment? What if they, are older and very, very forgetful? They really may be misplacing their medications. They really may be frequently refilling their drugs because they really don't know where they put the drug. All right, so some of your cognitive impairments and some of your dementias. What if, again, it's a younger person, an adult, a mom or a dad, but they have a teenage child? Maybe it's not the mom or dad. Maybe it's that they don't realize the children or their adolescents are taking those drugs or taking them and selling them on the street. So again, it may not be them that we're focusing on. It may actually be a family member that is doing that. Okay. Prescriptions may not be the right dose or the right frequency, and the patient's having a lot of breakthrough pain. The physician won't increase the dose or increase the frequency, so they take them on their own. All right. Doesn't mean they're having an addiction, just means the pain is not being managed and they're having to come in and refill their drugs on a frequent basis. All right. Again, going to different ERs to obtain the opioids. Usually if it's for pain purposes, it's because they are not getting pain managed. Sometimes it's that they're not insured or their insurance doesn't cover office visits when it would cover their ER visits. Telling inconsistencies. They may have a cognitive issue like a dementia. They may have an underlying psych disorder, but that doesn't mean it's an abusive situation or disorder. And they may have memory problems. It may have been an old head injury that continues to have some memory deficits. So you can see as we go into there, anytime we get a red flag, we can play a devil's advocate to that red flag. So there's no cut black-white to this. Unrelieved pain produces manipulative behaviors. All right, so the harm done by not treating pain is usually greater than the harm done by giving a patient pain medication when they're asking for it. All right, the big thing in the way of ethics is that we don't want our patients to experience pain just because we don't believe them. All right, so again, knowing situations are going to vary a little bit. I know that there's probably some pros and cons to that. But I think overall in the acute care facilities settings that we need to treat pain. All right, that we need to not say, hey, it's an addiction. We need to look at it as being self-reported. So what are some interventions? All right, number one, we need to be honest with the patients. If we suspect there's an addiction, then sometimes it's truly being honest with them on that. Say, look, we have the state registry. It looks like you're getting a large number of prescriptions. Looks like you're using different physicians to get these prescriptions. Let's talk about this. This is a concern because it appears that you have an addiction to these drugs. Be honest with them. Sit down, review their medication history, find out what is going on. Find out what drugs they are actually currently taking and which ones are being filled by pharmacy. Explain to them some of the consequences, the side effects. You can have, if you take all of these drugs, always these polypharmacy, they'll come in with Percocets and Loratabs and Dilaudids and morphines and Imiscontins, and you're like, you're really taking all of this? It's way too many different types of drugs, all right? There's no combining these to one. So you talk to them, consequences, respiratory depression, you can have overdoses, you can die from this, you can develop opioid headaches where every single time you take an opioid for pain, you're going to have a headache. Most people who have these opioid headaches stop taking opioids. The headaches are more severe than what their pain is. If it's got Tylenol in it, and all these combined drugs like your Loratabs and all, that has Tylenol in it. They can have acetaminophen overdoses. They can go into acute or chronic liver failure from that. Opioid-induced hyperalgesias. So sometimes it's going over what is the consequences and what is the potential side effects of all of these drugs that you may be on. Don't express a disbelief. All right? When we're doing our pain assessment, if we have someone who's constantly on that call button, I heard, it's a 10, and they're laughing and talking on the phone, don't walk in and say, hey, I don't believe your pain is a 10. All right? That's expressing a disbelief, all right, of their complaint of pain. You can sit down and say, talk to me a little bit about your pain. Have you ever had pain before? How would this pain relate to that? If it's a 10, usually when we say it's a 10, you can't do this. Talk to me about that. Can you get up? Can you move around? Maybe this is a 6, but don't express disbelief. That's where you lose that trust relationship with your patients. You lose your trust relationship. We're not going to be able to control somebody's pain on that. Determine the potential cause of the underlying pain. Make sure it's being addressed. Make sure we're not just covering the underlying etiology with pain medications. Again, make sure we're treating it with the right pain medications. If we feel like it's a neuropathic pain and they're on all these opioids, then it might be getting them off of the opioids. And remember, you don't suddenly stop them. You start to titrate them down as we're increasing their anticonvulsants or antidepressants on that. Refer them to specialized clinics, to pain managed clinics. Discuss with them potential strategies to decrease their opioids. If you have them coming in with these large prescriptions and numbers, use some non-opioids. Use some invasive like joint injections and spine stimulators. Use some adjunctive therapies like your anticonvulsants, antidepressants, caffeine. Again, depending upon what the underlying disease process is. Assess what other problems may be causing the overuse of their opioids. What you may find out is they are taking it not because of an addiction, not because they're hurting, but because it's helping them with some other problems they may have, like an inability to sleep. So you have someone who's got that prescription of that opioid. They lay down, they're really not hurting, but it's been a rough day. And it's like, oh man, I can't sleep, I'm laying here. I know that Loratab will let me sleep. And they take the Loratab. So they may be using it because they can't sleep or because they're anxious and they know they're going into this really big event or an anxious, anxiety producing meeting. Take a little bit, take the edge off, all right? That's how sometimes the overuse of the opioids begin, all right? It's actually using it for those kinds of side effects versus the highs that can start to lead to the abuse situations on that. There's a lot of use nowadays of opioid contracts or pain management letters. We've used them for a while in pain clinics, but it is now becoming more and more common even in the acute care settings. And for example, on an opioid contract would be, we're going to manage your pain with these certain drugs if we find that you're getting opioid prescription from other suppliers, then we will no longer manage your pain. Or if we do a random drug screen and we find that you have a barbiturate in your system that was not a prescribed drug, then at that time we will no longer provide your pain management. So these are your contracts, all right, that you can make with patients on that. But again, the way of treating pain, err on the side of treating the pain if in doubt. It is really not ethical to withhold pain meds in a person that has pain, even if they have an addiction. So they come in, they've got a fracture, they've had surgery, or they've had a trauma. They have a history of a known addiction. It is still unethical to withhold pain meds from them. So hopefully I'm not speaking to people who do that. Hopefully we just see it, because I'm probably speaking to the choir on that. But we do have to keep in mind we've got to treat pain, whether they have a history or whether we suspect they have a history or not. So again, to provide the care that we should be providing, we need to accept and we need to respect their reports of pain. But we need to still have management plans. For example, if I always dilute my morphine in 5 cc's of saline, then if my patient asks me to give it without any dilution, I'm not going to change my practice. I'm still going to dilute it in 5 cc's of saline. If they tell me to give it rapidly, and I would not have given that drug rapidly to anyone else, I'm not going to change my practice. I'm going to give it slow, and I'm going to do it like I need to. These are your management plans that can still be followed, all right? Even though we respect and we accept that they have pain, we need to still, follow some of our management plans to make sure that we administer it correctly. Some of the ways that I've seen ER physicians do it, or even discharge from an acute care facility with a follow-up appointment being made to their primary care physicians, is we may limit the number of days of supplies of opioids that we give at the time of discharge. So if this person is, I'm on vacation, I didn't get enough of my drug to get me through, then we give them the prescription to get through the next 3 days of their vacation, but that's it, all right? Or I give them enough time to get them to the clinic to see their outpatient physician, and that's the supply they get. So these are ways of dealing or treating patients with pain that come in that have histories of the addiction. If you have someone who has an addiction history, but it's also chronic pain, then what we want to do is use more of your longer acting than your shorter acting. Even in the acute care facility, if they're going to be on pain medications, they're taking them on a regular basis. We know they've got a tolerance to respiratory depression based on their history of what they take. Then what we might do again is do longer acting and less short acting. Shorter acting opioids have higher rates of addictions. They give more of that high to them than the slower release drugs, all right, patches, things like that. Methadone is a longer acting drug, has a little less development of tolerance. Problem with methadone is you do have to watch your QT interval, and we'll talk more about that when we get into pharmacology on that. Tramadol is another drug that's used frequently for patients that are known substance abusers or addictions. It is still working on the mu receptor, but it's a partial mu receptor agonist. It's a manufactured drug that is not considered to be a pure opioid. And because of that, they believe it is less addictive. Now, that doesn't mean it's not addictive, because it is. It will work on those mu receptors, and there is some feel good, some high that you get from it. But it has less addictive properties, or potentially less, than a lot of the other opioid substances. So tramadol may actually be a drug of choice in treating substance abusers who have pain. Now, it is not like any of the other mu agonists. There is a ceiling. So it's not like morphine that says you can give as much as you need to till you control pain. We do have ceiling doses, but it's an option. The other option is Precedex, particularly if they're in the ICU, because Precedex is an alpha agonist. It is not an opioid. It doesn't have any of the high or the addictive qualities to it. It has been used to help with alcohol withdrawal. It has pain or analgesic effects to it, and it is somewhat of a sedative, all right? But there's no habituations, there's no dependency, no addictive properties to it. And like we said, in other areas, get outside of the opioids. Look in chronic pain management of these patients that have histories of substance abuse. Try things like the Elavil or the Neurontin. All right, again, get away from those opioids. Utilize non-opioids, utilize complementary methods, use IV acetaminophen. It has actually been found to be very effective in pain management. In fact, a lot more than the oral route of the Tylenol. So instead of withholding, again, think around. What else can we give patients that are histories of substance abuse but actually have pain? Topical lidocaine patches, injections, blockades, spine stimulators, acupunctures, and TENS. And all of those can also be used to get them off of opioids when we're trying to titrate them down and get them to use less. Okay? Avoid excessive negotiations, and sometimes even use a PCA. I know a lot of people are like, oh, wait a minute, it's a substance user, it's an addictive properties, the patient has these addictions, why would I give them a self-administering drug like a PCA? It's because you give the control back to them. And when they have that control, and they're not always having to ask you for their analgesics or pain meds, then when they have that control, they sometimes can actually have better pain management with this, all right? So they're not having to tell you they hurt. They can take that when they need to. There's still lockouts. There's still all your interval lockouts, your max doses. So it's not like they can take as much as they want, but it does provide some of that control back to them. If they're in the hospital, you have a pain specialist or a pain team, definitely consult that pain team. If they're on drugs at home, even if it was for a non-pain purpose, don't stop the drugs. Just because we don't believe that they should be taking those drugs doesn't mean I want to suddenly stop them, because they can withdraw. All right, and we don't want to be withdrawing patients in the middle of the acute care settings for whatever purpose that they're in on that. All right, so you have to monitor for withdrawal symptoms, whether their substance was an opioid, a benzodiazepine, or alcohol. We still need to look for substance withdrawals from those. Be prepared to administer higher doses, even in a substance abuser, because whether the substance was used for pain or for an addiction, overall they're going to develop a physical dependency and a tolerance to the drug. They actually require more of the drugs to get the pain relief. All right, again, these are acute pain patients on that. And then we also run in the other direction. Sometimes you have a patient who comes in who has a previous history to addiction. All right, remember, they never truly get over their addictions. They had been a substance abuser. They find that they've been off of that substance for the last 2 years, but now they come in for an acute pain purpose, or they develop a chronic pain syndrome. They're gonna sometimes say, should I take the drug or not? You don't walk in and say, oh, here's your morphine, and have them take it if they didn't get properly some education review on that. We do know that there's a high relapse rate for patients that have had previous addictions, and we give them opioids in the hospital. Even if it's for acute pain management, we can see the higher addiction. So people need to make that decision. Do they want to tolerate their pain and use things like non-steroidals, or do they want to go ahead and take an opioid and know that they have a risk of increasing their craving and a relapse, even if they've been abstinent from that drug for the last 2 years? All right, that needs to be up to the patient. It doesn't need to be, we're able to sit down with them and give them pros and cons and give them the education they need, but for making that decision, sometimes that decision is truly up to the person that has been addicted in the past. All right, so looking in kind of the final, we know there's no black and white. It is very hard to differentiate an addiction from a use of a substance for pain management. If you have somebody with a known reason for have pain, or they develop a chronic pain syndrome, we have to treat their pain, whether they have a history of addiction or not. We can be, imaginative sometimes in trying to treat pain by adding opioids, non-opioids, adjunctive treatments, but we still need to address pain. And we should always, always, always treat our patients with respect. Even if we feel like it's the addiction, if the patient says they have pain, we treat them with respect and we believe them. Thank you very much for joining us today in the module of addictions and physical dependencies and pseudoaddictions.